Today we're going to talk about the physiology of pain and of a few ways of controlling it. We'll deal with medication, of course, but also with a new technique, electric nerve stimulation. Pain is almost always a warning sign, telling us to take better care of our bodies. Whether it acts as a reflex of defense, notifies us of an oncoming illness, or forces us to rest. Almost always, pain plays a protective role. Before we understood how the nervous system functioned, pain was considered an emotion. People suffered, but it was all in their heads. Pain was a subjective discomfort of the soul and the heart. Today we know that pain is physical, that it is associated with the nervous system and is transmitted by an assortment of chemical and electric signals. Every instant, our body sends information to our brain about dangers threatening it. But how do these pain stimuli get there? That's what we're going to find out right now. Pain protects us. It warns us of the presence of a possible threat to our body. If we didn't feel pain, we would often mutilate ourselves without being aware of it. Our lives would be in constant danger. But how does pain warn us of an injurious agent? Let's take the example of a pinch. A first sharp and clearly located pain is felt as soon as you've been pinched. Then you feel a second pain, belatedly, more diffuse, longer lasting, harder to bear. Before being interpreted as pain, the pinch is first detected by receptors. The receptors are little organs buried in the skin. They are attached to the nerve fiber endings. They code the intensity of the pinch into electric impulses. The signal is then sent along the nerve fibers to the spinal cord. When it reaches the spinal cord, the signal is then transmitted to other nerve fibers leading to the brain. Two kinds of nerve fibers convey the signal, alerting us to the fact we have been pinched. The structure of one of the two types of fibers is such that it conveys the signal to the brain quickly. These are the fibers which are responsible for the initial pain sensation. The other type of fiber carries the signal more slowly, which explains why the second painful sensation is belated. Before they reach the cerebral cortex, the pain signals go through various structures at the base of the brain, including the thalamus. Once they have reached the cortex, the signals meet up with the areas in charge of sensitivity, motivity, emotions, and memory. Here they are analyzed. The conclusions of the analysis carried out by the various parts of the brain establish awareness of the pain, together with a series of responses. The initial pain triggers typical motor responses, such as withdrawing from the source of pain, whereas the second pain is associated with emotional reactions, ranging from plaintive moaning to cries for help. The variety of responses displayed by different people to the same injury, or by a same person, depending on the circumstances, indicates clearly that pain is a subjective and individual experience. Memories, cultural attitudes, and the degree of anxiety of the moment, as well as how the cause of pain is interpreted, are all factors that contribute to the variety of reactions. And yet, odd as it may seem, all normal individuals will feel pain when the injurious agent reaches a certain point, like, for example, at temperatures just exceeding 45 degrees Celsius. A person said to have a very low pain threshold is not someone who feels pain more intensely, but rather someone who tolerates pain less and reacts to it strongly. Injurious agents that touch the skin constitute one kind of pain. However, there are many others. Take, for instance, pain that affects our internal organs. That type of pain can play terrible tricks on us. For example, why is it that a pain originating in the heart is often felt in the left arm rather than in the heart itself, given the fact that the arm isn't hurt? Projected pain such as this is explained by the fact that the nerve fibers from the heart and those coming from the left arm transmit their pain signals to the same spinal cord fiber. This fiber conveys the signal to the brain. In normal, everyday circumstances, the brain is more accustomed to receiving pain signals from the left arm than it is from the heart. If at a given moment, during a heart attack for instance, the pain signal really comes from the heart, the brain will interpret it as coming from the left arm, simply by habit. Even when pain no longer has its raison d'être, such as in cases of imaginary pain or phantom pain felt after an amputation, the pain itself feels no less real and can seriously affect quality of life. The fact remains that pain protects us from many potentially injurious situations. Did you know that a person who has had a limb amputated can continue to feel pain in the limb that has been removed? Some people go so far as to try to pick up things with their phantom hand or jump out of bed on their phantom leg. In spite of all our knowledge about the transmission of pain stimuli, there still is no satisfactory theory to explain that peculiar pain. Pain is an extremely complex sensation. It results from an assortment of physical, psychological, and moral variables particular to all individuals, and which determine how we will cope with it. The circumstances causing pain are important. A dancer finds it quite normal to go to the furthermost limits of extension and muscular exertion. A soldier in action will handle a wound much better than a civilian who is injured on the job. But some people will react almost hysterically to something as trivial as an injection. Many chemical substances can relieve pain. How these substances work has only been understood since the discovery of our inner pain control systems. These inner systems control pain by interrupting pain signals before they reach the brain. They affect nerve fibers originating at the level of the thalamus and the surrounding structures at the base of the brain. The nerve fibers descend into the spinal cord where the pain signal is relayed. The pain signal picked up by the skin receptors goes via the nerve fibers to the spinal cord, where it is relayed to other nerve fibers that go up to the brain. It is at this relay point that the descending fibers exert their control over the pain by preventing the pain signal from being transmitted to the brain. The inner pain control systems function by releasing specific chemical substances. These substances are called neurotransmitters. The neurotransmitters that come into play in controlling pain are noradrenaline, serotonin, and endorphins, whose chemical structure is very similar to that of morphine. Morphine is a derivative of opium. Opium, which is extracted from the poppy, has been used for controlling pain for over 2,500 years. It's an interesting coincidence, or gift of nature, that the composition of morphine and of other similar substances called narcotics very much resembles that of endorphins, which activate one of our pain control systems. Given this striking resemblance, morphine and other narcotics are capable of imitating the action of endorphins. When injected into the organism, they activate the inner pain control system. Once activated, the system blocks the pain signal in the spinal cord before it can reach the brain. Tricyclic antidepressants are also highly effective drugs, which are used to relieve certain types of pain, such as migraines, cancer pain, and arthritic pain. These substances are normally used to treat serious cases of depression. However, their effect on physical pain is clearly different from the one they have on depression. These tricyclic antidepressants will relieve pain when administered in weak doses and for shorter periods of time than required to treat severe depression. But how do tricyclic antidepressants relieve pain? By concentrating and prolonging the action of the neurotransmitters which, like morphine, set off the inner pain control systems. This intensifies the blocking of the pain signal at the level of the spinal cord. There exists another class of well-known substances which help to alleviate lesser pains, such as headaches, muscle pain, and pain caused by an injury. These are salicylates, which include aspirin. These substances act mainly on the pain receptors located in the skin. The minute we injure ourselves, a host of chemical substances is released to the injured area. Among them are prostaglandins, which activate the pain receptors. The prostaglandins help to detect the injury and thus to send the alarm signal along the nerve fibers. Aspirin manages to alleviate pain by blocking the synthesis of the prostaglandins. By doing this, it deprives the receptors of helpful assistance. As a result, the receptors lose some of their ability to detect the injury and emit a pain signal to the brain. In short, the way pain-suppressing drugs work is by inhibiting the transmission of pain signals. But where they work depends on the type of substance involved. Relieving the symptom of pain isn't enough. The doctor has to examine the injury or the underlying illness. This is relatively easy in the case of some acute pains. But what happens when an acute pain ceases to be a warning signal and becomes chronic? When pain subsists for more than 3 months, It is no longer considered a symptom. The pain itself becomes the illness. Today, medicine is making real attempts to relieve patients suffering from chronic pain. Special rehabilitation programs are being set up, and doctors are even combining very ancient techniques, such as physiotherapy or hypnosis, with modern ones, such as transcutaneous electrical nerve stimulation. Would you ever have imagined that sciatic pain could be relieved for several hours by stimulating a nerve electrically, just by putting electrodes on the skin? And yet this is a recent and effective means of treating pain. Transcutaneous electrical nerve stimulation, commonly called TENS. Transcutaneous electrical nerve stimulation uses an electric current to inhibit the transmission of pain signals. Placed on the skin, following the pathway of the nerve leading to the painful area, an electrode connected to a battery stimulator can generate an electric field strong enough to activate the large nerve fibers in that nerve. These large fibers normally transmit light tactile sensations, such as tickling. In the spinal cord, these large nerve fibers interact closely with the smaller nerve fibers, which actually convey the pain signals. Stimulated by the electric field, the large fibers can interrupt the transmission of the pain signal and thus provide relief from the pain. TENS is a very desirable form of therapy for many types of pain because it avoids the side effects that accompany many drugs or narcotics. Transcutaneous electrical nerve stimulation can be used to relieve certain chronic pains, lower backache for instance. It can also alleviate post-operative pain. However, chronic pain that is vague, difficult to locate, such as visceral pain and psychological pain, cannot be helped by this treatment. The only disadvantage of transcutaneous electrical nerve stimulation lies in the long-term use. In many patients, its effectiveness tends to decrease over time. Just recently, researchers concerned with chronic pain syndromes have developed a most remarkable surgery to relieve pain which refuses to respond to treatment. The surgery consists of stimulating the posterior cords of the spinal cord, which are responsible for pain control. An opening is made on the skin in order to insert the electrode into the epidural area without touching the spinal cord. The neurosurgeon inserts the electrode under televised control. That region of the spinal cord is gradually stimulated until vibrations occur in the painful area. Here, it is in the right leg. The patient remains conscious throughout the operation and notifies the surgeon whenever the stimulation provokes a slight vibration in the area where he felt pain. The electrode is fixed at the outlet of the spinal column. It is connected to an electric impulse generator. The generator is placed in a small pocket on the lower part of the thorax, on the side the patient has chosen. A special connector links the impulse generator and the electrode. This type of implant is used, for example, for chronic pain due to spinal column injury or peripheral vascular trouble. Since just recently, it is also being used in angina cases that do not respond to other treatment. The doctor programs the parameters of the electric impulse generator. It may eventually be readjusted if necessary. Since the electrode is implanted permanently, the patient administers the treatment using an impulse generator whenever pain is felt. The impulse generator works according to instructions in its memory bank. The electric impulses are transmitted along the wire to the electrode implanted in the spinal column. The inner pain control nerve mechanism is then activated, which provides relief. Electrodes can also be implanted in a part of the brain called the thalamus to relieve certain facial pains or pain from amputated limbs. While the implantation of electrodes in certain areas of the nervous system is very delicate, people plagued by chronic pain experience such an improvement in their quality of life that the surgery is well worth trying. I haven't discussed pains of the heart and of the soul yet. Failure, loss of a loved one, desertion. Don't be fooled. These kinds of pain are just as real as the pain of being hit by a stick or injured in a car accident.